Welcome to the Just Hard podcast. Real nurses, real talk, real life. Where we take the nursing textbook and drop it right into the hospital setting. Where real nurses have real conversations about the tough stuff. Because in nursing, hard isn't the enemy. It's the making of you.
I'm Chelsea Justice.
And I'm Lisa Harding.
We are two nursing faculty who believe in teaching with honesty, heart, and a whole lot of practical wisdom. We know that nursing school isn't just challenging, it's transformative, and we're here to help make that transformation clearer, more doable, and yes, even a little fun.
Every episode, we'll break down the hardest concepts of nursing, show you how they actually show up in practice, and give you the tools to think like the nurse you're becoming. We'll share our real-world stories, the lessons we learned the hard way, and the moments that pushed us and our students to grow.
So settle in, breathe deep, and remember,
It's just hard, and we can do hard things. Welcome to Just Hard, real nurses, real talk, real life, where we take the nursing textbook and drop it right into the hospital unit.
On today's episode, we are going to have the Neuro Neighborhood Watch Edition. We are going to start off with brain tumors. In this episode, the neuro floor is a neighborhood. The diagnoses are dramatic, and every shift feels like the HOA is out to get you.
If it's chaotic, confusing, or clinically cursed, we're covering it. Because in this job, it's messy, it's wild, and honestly, it's just hard.
All right, let's get into today's hot mess, brain tumors, the new neighbors who showed up uninvited and immediately started taking up space.
So let's talk about what moves into the brain community, primary tumors and metastatic tumors. The primaries are born and raised here. Glial cells, meninges, Schwann cells, pituitary.
But remember, the neurons aren't the problem. They're too busy trying to conduct impulses and mind their own business.
Right? But the glial cells, they multiply, they gossip. They show up with Tupperware, and then they turn into tumors. Classic PTA moms gone rogue.
So when a tumor moves onto your block, patients show up with the classic neighborhood complaints. I have headaches. I keep tripping over my own feet. I saw a flash of light, and now I think my aura has an aura.
Those are the most common symptoms, aren't they? Or they always have the vague, I don't feel like myself, which in neuro means something is either swollen, compressed, blocked, or the brainstem is filing an HR complaint.
Intracranial pressure, ICP, the neighbor you wish would move. Increased intracranial pressure is that neighbor, the one who calls the cops on the block party but is also hosting their own illegal fireworks.
I do have those neighbors.
I do too. It's actually quite great on the 4th of July. I don't have to go anywhere.
And it saves you money. You don't have to buy them all.
I give the dogs a trazodone and I just sit out and watch the fireworks.
Seriously, my dogs are constantly drugged. Yes. So when increased ICP, the early sign is a change in the level of consciousness, or LOC, always.
Then we might have headache, vomiting, and those are late changes too if we're having vomiting, pupillary changes, ipsilateral. So this is a little bit different than when we had talked about stroke patients in the past. When you have intracranial pressure, your pupil changes occur on the same side as the pressure because it's pressing on that optic nerve. Motor issues and seizures.
And then Cushing's triad, because you'd always have to have some fancy name for something. Cushing's triad means three things: hypertension with a widening pulse pressure, meaning the difference between your systolic and diastolic blood pressure, bradycardia, and irregular respirations.
And that is a bad late sign, right, Lisa?
Yeah, they are circling the drain for real.
Yep, they're about to herniate. All right, neighborhood troublemakers. Gliomas. These originate from the glial cells. They go wherever they want, like they're taking a jog.
Glioblastoma multiforme, grade 4 astrocytoma, fast, aggressive, zero boundaries.
And then we have meningiomas.
90% of these are benign, but still blocking traffic with bake sale energy.
Oligodendrogliomas are slow-growing hipsters that steal your Amazon packages.
No doubt.
I have 2 neighborhood dogs that steal my Grubhub delivery and occasionally now my Amazon package.
That's insane. So you just come home and everything's spread out over the lawn?
Yeah, well, it used to just be my Grubhub. The one girl, Shiner, ate my ribeye one time. She was just gnawing on the bone in the front yard.
Can you blame her?
No, and she had just given birth, so she was real malnourished. And So yeah, so I had to like take my potato, and I was just trying to get what was left of the juice.
You have to share your steak and potato with the
Yeah.
neighborhood
I
dog.
still give her a treat. She comes over every day and I give her a treat. But then my other Amazon package was completely shredded, and I was like, this isn't even food. And the other one, Bootsy, he destroyed it, and he tore off the corner of my new book that I was about to read, and he even left his muddy paw print right on the page as a signature.
So when you tore off the cover, could you still read it though?
Yeah, I was able to. I'm reading it now, actually.
Okay,
Yeah,
perfect.
it's a little challenging. But
Little
I was-
memories.
Yeah,
Love
yeah.
it. Neighborhood dogs. Gotta love
Yeah,
them.
so those are the oligodendrogliomas.
So acoustic neuromas, excuse me, those are exactly what they sound like, acoustic. So think about in your hearing, arise from cranial nerve 8. And with this, you have balance issues, tinnitus, ringing in your ears. So these are the neighbors who keep hitting your mailbox.
Pituitary tumors, the utility company, hormones everywhere, drama everywhere.
Oh, yeah. Hormone dysregulation is a disaster.
Mm-hmm.
So now we should talk about herniations. This is when the neighborhood evacuates the brain.
If the intracranial pressure rises, the tissue shifts, and this is never good because the brain is in a skull, which is a fixed shape.
Yeah, I can't manipulate the size of the skull. It's already there and it's not changing. So when that happens, uncal herniation compresses cranial nerve 3, and we see this reflected as a blown pupil. This means the pupil is dilated and non-reactive.
And then central herniation, failed trust fall.
Tonsillar herniation. The brain stem is sneaking out the back door, and when this happens, it is fatal.
It is fatal. So what can we do to try to prevent it from getting to that level? So fixing the neighborhood chaos. We need to involve the HOA. The neighborhood chaos is giving the HOA a meltdown, noise complaints, a swollen cul-de-sac. First, we can start with Decadron or dexamethasone, the steroid that rolls in like, everybody calm down, tight junctions, get information. Stabilizes the blood-brain barrier and shrinks vasogenic edema.
Then we bring in the hyperosmolar crew. So this is things like 3% saline or a medication called mannitol. This is the flood control team. They pull the fluid out of the brain. They're like, pack your bags, you're being evicted. So we also manage blood pressure like we're trying to keep the peace at a family reunion. Not too high and not too low. This is Goldilocks perfusion. We want everything to be just right.
Yep, enough to perfuse the brain without making it even worse. And you know tumors love throwing seizures without a permit, so we send in Keppra, neighborhood security, shutting it down fast. If things spiral, patient might need to be intubated and hyperventilated. If we hyperventilate them, it can blow off some of that extra CO2 and allow vasoconstriction to occur, meaning less intracranial blood volume. It's a short-term emergency HOA-approved protocol.
There are some controversies in the literature right now about hyperventilation, so it's really patient-specific. Do we or don't we hyperventilate? Because lowering the CO2 is not always the best idea.
Right, and we want to make sure that we're oxygenating that brain as best as we can as well.
So when your neighborhood chaos hits max level, the craniotomy or a debulking procedure is the next intervention that we want to consider. We want to kick the tumor out physically, remove the skull cap if needed, and if the bone flap is gone, there's no getting out of bed without a helmet on. We protect that soft spot like a newborn.
Right, so we'll take out part of that skull flap to allow for swelling to occur. Got to keep that patient safe. We would not want them to have any falls. We had one patient that I remember, and he had a cranie without the bone flap, and he came to, and he actually had decisional capacity, and he was alert, and he was oriented, and he chose to leave the hospital against medical advice, which is his prerogative because he had that decisional capacity, and he went and he rode his bicycle without the helmet and the open flap, and then he fell, and he had an additional head injury, and he died.
Oh, wow.
Mm-hmm.
Wow. Every decision has a consequence, sometimes good, sometimes bad. I remember as a brand new nurse, I was a nursing student. We had a patient in a skilled nursing facility that had a brain injury, and he had an open flap, but there were no plans to replace it. I think it got infected or necrotic, so he didn't have a flap, and he'd been in a vegetative state for years. And we were, as brand new nursing students, trying to get him from the Hoyer lift into a wheelchair. And I remember one of my classmates having to put their hands over the top of that soft area as we're trying to swing him to get momentum to
So you
lift him
didn't bump
into the,
his-
yeah, it was rather hilarious.
Yep, so we got to be really careful with those spots.
Those fun nursing school memories.
All right, Lisa, I think we could take a quick commercial break.
Let's do it.
Do you or someone you love struggle with unexpected intracranial swelling? Is vasogenic edema turning your patient's brain into a crowded cul-de-sac? You're not alone, and now there's help.
Introducing dexamethasone, a corticosteroid proven to reduce inflammation and stabilize the blood-brain barrier. Dexamethasone works by tightening leaky capillaries, reducing fluid shift into delicate brain tissue, and lowering intracranial pressure.
In clinical practice, dexamethasone has helped countless patients breathe easier, think clearer, and feel relief from pressure-related headaches, all while creating more space inside the cranial vault.
Dexamethasone is fast-acting and effective for vasogenic edema related to brain tumors, inflammation, or compression. It's the trusted choice for providers everywhere when swelling threatens neurological function.
Do not stop dexamethasone suddenly, as this may result in rebound edema, because nothing ruins a shift faster than swelling making a surprising comeback.
Side effects may include increased appetite, irritability, mood changes, insomnia, and a sudden urge to recognize your entire life at 3 a.m. and reorganize it.
But when your patient needs rapid reduction of cerebral edema,
When the brain needs stability,
when the blood-brain barrier needs to get its life together,
ask your provider about dexamethasone.
because in neurocare,
Space matters.
And welcome back. We are going to talk about some central nervous system disorders, and we're going to start off with multiple sclerosis. So picture this house in the Neuro neighborhood. Oh, yep, cute from the outside, but inside the wiring is chaotic. Lights flickering, garage door ghosting open, Wi-Fi praying for survival. That's MS.
Right? MS is the immune system breaking through the blood-brain barrier, attacking the myelin sheath, and leaving plaques like graffiti on the axons. Now signals glitch, reroute, or fail completely.
Symptoms vary depending on which wire shorts out. You might have blurred or double vision, fatigue, weakness, ataxia, numbness and tingling, speech and balance issues. And then there's something called Lhermitte's sign, which is like an electrical shock sensation that they feel going down their spine. And then there's the MS hug.
The MS hug is not anxiety, not a heart attack, not reflux. It's literally the muscles around the ribs going into spasm because the nerves controlling them are irritated from demyelination.
Exactly. Damaged sensory nerves, mixed up signals, the intercostal muscles tighten like a vice. Patients describe a squeezing band sensation around their ribs, pressure like someone's hugging them too hard, crushing or tight chest sensations, or a corset that's 3 sizes too small.
Oh, don't put me down for that.
I'm so glad that we don't live in the times where we had to wear all those clothes and corsets every single day.
No.
Mm-hmm. Yep.
No.
So it's a neuropathic spasm, uncomfortable, sometimes painful, and often scary because it can mimic cardiac symptoms.
And it can travel. Some patients feel it in one area, then another, depending on which spinal nerves are irritated. It usually resolves on its own, but can flare with stress, heat, or fatigue.
Diagnosis requires MRI with plaques in multiple CNS areas and a lumbar puncture with oligoclonal bands. Treatment isn't a cure, it's maintenance. So these patients may be prescribed beta interferons, some steroids for flare-ups, or even plasmapheresis in severe cases.
And lifestyle matters. Avoiding heat, pacing activities, and fall prevention. So if you got to avoid heat, living in Bakersfield is probably not your best idea.
Probably not.
Or Death Valley, the hot strip of Vegas, Nevada.
Yep.
Oh, guess what? Now it's time for a word from our unofficial sponsors.
For people living with multiple sclerosis, the wiring can feel unpredictable, but now there's a treatment designed to help steady the system.
Introducing Ocrevus, proven to reduce relapses, slow disability progression, and calm immune system attacks on myelin by targeting CD20 positive B cells.
Ocrevus is given as an IV infusion every 6 months, one of the most convenient long-term MS therapies.
Infusion reactions may occur, but pre-medications help minimize discomfort. Side effects vary, so talk with your provider.
Because MS brings enough surprises, you don't need your immune system throwing a rave on your myelin.
Ocrevus, helping keep the light steady, one infusion at a time. Okay, next up, we're going to be talking about ALS. We're moving to a house in the Neuro neighborhood that deserves a different kind of tone. The ALS house. It's not chaotic or loud, it's quiet. And the silence is what makes it so heavy.
Yes, amyotrophic lateral sclerosis. This is the home where the power slowly goes out room by room. Not in a dramatic crash, just steady dimming. And the hardest part, the person inside stays fully aware through every change.
This has got to be very terrifying. In ALS, it affects the upper and lower motor neurons, the pathways that control movement, speech, swallowing, and breathing. But it does not touch cognition, intelligence, or personality. Fully aware, just not working.
Yep, so scary, just trapped in your body. And if anyone showed us that better than anyone, it was Stephen Hawking. His humor, brilliance, and sarcasm stayed untouched, even as his muscles weakened.
He joked that his computerized voice was better than the voice nature gave me anyway, and honestly, that's iconic.
He turned tragedy into jokes, barriers into research, limitations into a new way of imagining the universe. ALS never dimmed his mind, just his body.
What are the early signs? Early symptoms are really subtle. They may start with a weak grip. You might start dropping objects, get foot drop where your foot just doesn't follow along. You get speech fatigue. You can start off speaking normally, but your mouth gets tired from speaking. Fasciculations, little tremors, difficulty with fine motor movements. Small things to most people, but huge moments to the patient.
And over time, the floors of the house dim. The arms weaken, the legs weaken, speech becomes harder, swallowing becomes tiring, even breathing is tiring. We have to remember that your diaphragm and we have those respiratory muscles as well, and they begin to struggle. But the light inside the person, still bright, still fully aware.
So we really need to work with diagnosis and support. Getting diagnosed with ALS is long and emotional. It requires EMG changes to the myelogram. We need a muscle biopsy and ruling out everything else. It's almost a process of exclusion, saying it's not something until we define it as ALS. It's a process that needs patience and empathy.
And unfortunately, we don't have a cure. Treatment focuses on slowing progression and supporting the human, not just the disease. So there is a medication called Riluzole, which can help potentially slow the progression. The patients will need to work with physical therapy, occupational therapy, and speech therapy to, try to preserve what they have. But this is a very progressive and debilitating disease. Nutritional support at some point, if they choose to, they may require a feeding tube, breathing support. Eventually, a tracheostomy would be required. So we need to really have those open and honest conversations with the patient and the family about what their goals are, because these are the inevitable conversations that we'll have to have.
People with ALS are incredibly strong. They're emotionally strong, mentally strong, spiritually strong. Their minds stay sharp even when their bodies struggle.
Yep, and that's the key thing there is ALS dims the house, but sometimes the brightest minds live there. The person inside remains fully themselves, their humor, their intelligence, their personality untouched.
Our role isn't to fix ALS, it's to support the person living with it. We show up for them every day. That's the work.
Thanks, Lisa. I think this would be a good time for a quick commercial break. For people living with ALS, every moment matters. Every breath, every word, every connection. And while we can't stop ALS, we can help slow it down.
Introducing Riluzole or Rilutech, the medication proven to modestly slow the progression of ALS by reducing damage from glutamate, one of the chemicals involved in motor neuron injury.
Riluzole works at the cellular level, helping protect the nerve pathways that control movement and breathing. It's not a cure, but it's a step, a way to give patients just a little more time with the abilities they value.
Taken orally, usually twice a day, Riluzole has been shown to extend survival and delay the need for ventilation in some patients. Side effects can include nausea, fatigue, and changes in liver enzymes, so regular lab monitoring is important.
Riluzole isn't about giving false hope. It's about giving real support, preserving function, slowing decline, and helping people stay themselves for as long as possible.
Talk to a provider about whether Riluzole is right for you or your loved one.
Riluzole,
because every moment matters.
All right. Welcome back to the Just Hard podcast. We are moving into disorders of the peripheral nervous system, and we are going to start off with myasthenia gravis, the house with the failing power supply. All right, so imagine a house in the peripheral nervous system neighborhood that looks totally normal from the outside. Cute paint, fresh mulch, wind chimes. That's kind of how my house looks. It's really cute. But inside, the power is unreliable. Lights turn on, then dim, then flicker, then turn off because the house is tired.
That's myasthenia gravis. I don't know why, but myasthenia is kind of one of my favorite neurologic disorders to talk about. I don't know.
I've had two, and it's pretty rare. In my career, I've been a nurse since 2011, so however many years that is.
Long time. You're old.
Yeah, long. Yep. Two patients that I can think of that I can recall very vividly that have had myasthenia gravis. One in particular stands out to me very, very much so.
Yeah.
He was an older gentleman when I was working up in Reading, and yeah, I'll never forget him.
Yeah, I mean, these patients with these chronic neurologic disorders are often just the most humble and sweet people. I love when we're allowed to have a glimpse into their lives and they share their lives with us.
Yeah.
What an honor it is. All right, myasthenia gravis. It's literally the house where the electrical system works early in the morning, but by lunchtime, the whole place is running on 2 extension cords and a prayer.
What's actually happening? At every neuromuscular junction, nerves release acetylcholine, the spark that tells muscles to contract. But in myasthenia gravis, antibodies attack the acetylcholine receptors, so the spark has nowhere to land.
It's like the house has 100 electrical outlets at 8 a.m., but by noon, only 17 still work. And one of them sparks when you plug it into the toaster.
So what's happening clinically? The first few muscle contractions look great, nice, strong signal. But after repeated use, the remaining receptors get overwhelmed. The muscle says, "Bestie, I'm trying, but I'm exhausted."
That's why myasthenia gravis weakens. It's fatigable, meaning the more they use it, the weaker it gets. Rest equals recharge. Activity equals shutdown. These people cannot be marathon runners.
Right, and symptoms depend on which circuits are glitching. So ptosis, that's the one where eyelid slowly droops down like it's done with everyone's nonsense. Diplopia, vision can't decide which reality it wants to commit to. Facial weakness, the smile that starts strong but falls apart halfway through like bad mascara. Bulbar weakness, trouble chewing or talking, especially at the end of the day. Dysphagia, because the throat muscles are clocking out early. Neck weakness, can't even hold your head up after prolonged use. And then, of course, the respiratory weakness where the diaphragm says, "Listen, I've done enough."
Yeah, respiratory failure, alert, alert, red flag, caution,
always worried.
caution.
And I remember with my patient that we had, we really wanted to avoid intubating him at whatever measures possible because we knew that once we put him on the ventilator, the pulmonologist said that those lungs are going to be breathing so easy that we're never going to be able to get him off.
So did you use CPAP, BiPAP with him?
He ended up going on hospice. He ended up, he did the plasma for, no, he didn't do that. He did, I just remember he was on dialysis and he had said the dialysis was painful and he didn't want it anymore and he didn't want to live anymore, but he didn't want to tell his family that, his wife of like however many years, like they were one of those couples that have been together longer than I've been alive.
Like Dave and Lisa Harding?
Mm-hmm. Yeah. And I remember like the night before he went home on hospice, like we let her stay the night. So we put her bed next to his bed in the room and they slept in there together and they had that night together. And then he went home on hospice the next day. But I do remember we never did intubate him and he was tough, but yeah, he was just done. He was just done fighting and he said all the treatment, it was painful. And he was just done.
Yep. Patients have the right to do that.
Yep.
Yeah. So myasthenic crisis is when respiratory muscles get too weak to maintain ventilation. This is the house where the power doesn't just flicker, the generator fails.
Diagnosis vibes, we're going to check them for AChR antibodies. That's the smoking gun. We're also going to test them for something called MuSK, M-U-S-K antibodies. EMG showing fatigability, ice pack test. And there's something called a tensilon test, which is a little bit old school but more iconic.
Yeah, a tensilon test is really the way to see if it's a myasthenia crisis or if it's cholinergic crisis, what is happening with it. The treatment focuses on improving communication at the neuromuscular junction and calming the immune system. So basically, we have the impulses jumping across the cleft to where we're trying to get the enzymes to jump across. They go across and then they hit the receptors, but there's not enough receptors there. And then once they get there, the enzymes aren't there, and so they hang on. So that's the goal, that we want to keep that impulse there as long as we can. So some of the treatment is like pyridostigmine, which is really hard to say. It lets acetylcholine hang around longer. So acetylcholinesterase, which breaks down acetylcholine, is usually staying there, but we can block it, and so the acetylcholine stays there. So then we get muscle contractions that last longer. Steroids help because immunosuppression is nurse magic. This is an immune compromised disease, and so what we want to suppress the immune system so that it doesn't attack itself. So azathromycin, these are long-term immune regulators. IVIG or plasmapheresis is what we do when we have severe weakness or if the patient is myasthenic crisis. And then there's a thymectomy. So there's some suspicion that the thymus gland is acting suspicious, and it's what's causing part of the problem. And so then if we take the thymus gland out, then we no longer have that problem.
In myasthenia gravis patients, they're very sensitive. Heat, stress, we're kind of seeing a common theme here with these neuro patients, right? Heat, stress, overexertion, illness, certain medications can all help flip that breaker.
So myasthenia gravis, the house is where the wiring works, but not for long, and not if you ask too much, and definitely not on hot days, and absolutely not if the neighbor's kid is sick, and never if you give them the wrong antibiotic.
It's the house that needs naps, AC, scheduled rest breaks, and supportive neighbors who don't overload the system.
That's a house I think I want to live in.
I think so too. And now it's time for another commercial from one of our unofficial sponsors that does not pay us. Today's episode of Just Hard is brought to you by absolutely no one. We are not getting paid for this, but if we were, this would be the perfect spot for Mestinon.
Mestinon, also known as pyridostigmine, is the most commonly used medication for myasthenia gravis. It works by blocking acetylcholinesterase, allowing acetylcholine to stay at the neuromuscular junction longer.
Translation, your muscles actually get the memo. Less drooping, less weakness, and fewer my eyelids hate me moments.
When taken as prescribed, Mestinon can help improve muscle strength and activities like swallowing, breathing, and even just staying awake without your eyelids filing for early retirement.
Side effects may include increased salivation, sweating, abdominal cramping, and brisk GI activity, like you better know where the bathroom is activity.
Because Mestinon doesn't play. It gets everything moving.
But overall, it's considered safe, effective in the first-line treatment for myasthenia gravis symptoms. And again, we are not sponsored, although we wouldn't decline a tote bag.
Mestinon, helping myasthenia gravis patients stay stronger, move better, and feel more like themselves.
Ask your neurologist if Mestinon is right for you.
This has been a completely unpaid message from Just Hard.
Seriously, not a dime.
Nothing. But feel free to donate.
Yeah. We like coffee cups, tote bags,
gift cards.
And now, welcome back to Just Hard, where your favorite hosts break down the most confusing disorders with the energy of two women who have had 3 coffees and 4 regrets.
Tonight, we're talking about Guillain-Barré syndrome. The guest at the block party who starts at the street corner and somehow ends up climbing the whole house.
Ascending paralysis. Love that for us.
What is GBS or Guillain-Barré? So Guillain-Barré syndrome, or GBS, is an acute autoimmune attack on the peripheral nervous system. The immune system gets confused and thinks, hey, those nerves look suspicious, and goes full SWAT team on the myelin sheath.
It's basically your body sending a "you up" text to the inflammation at the worst possible time.
Causes and risk factors. Guillain-Barré usually shows up after a respiratory or GI infection, or occasionally after a vaccine like flu or rabies. It's not the vaccine itself. Let me say it again for the people in the back. It is not the vaccine itself. It's the immune system overreacting like it's auditioning for a telenovela.
Yes, good point. Thank you for clarifying that it's not the vaccine itself. It can also be associated with things like Hodgkin's disease or lupus. Men and women are equally effective, and Guillain-Barré does not discriminate. It ruins everyone's day equally.
So here's the nerdy part, the patho. Here's what's actually happening. Macrophages damage the myelin between the nodes of Ranvier. With the myelin gone, impulses slow down or get blocked completely. The myelin is really the insulator to help the impulse travel down the neuron.
Think of it like the HOA of your nerves fired the maintenance team. Now the electrical signals are tripping over potholes.
Usually the axons stay intact, which is why recovery is possible. But the autoimmune attack causes ascending neuromuscular paralysis.
You heard that right. Ascending starts in the legs, works its way up like a slow moving horror movie villain.
What are the clinical manifestations? Symptoms progress over hours to up to 3 weeks, and the hallmark is progressive symmetric weakness, not unilateral. It's going to start both feet, both legs, both hands, not one over the other.
Right. Legs to hips to trunk to arms. And in about 85% of cases, cranial nerves join the party too.
Facial nerve, hit. Vagus nerve, definitely hit. Autonomic dysfunction, oh yes. Blood pressure swings, arrhythmias, diaphoresis, ileus, urinary retention.
And up to 40% end up in respiratory failure. Remember that diaphragm is a muscle, both voluntary and involuntary. So if GBS were a neighborhood or a neighbor at the block party, it would be the one setting off all the illegal fireworks inside the garage at 2 in the morning.
Never good. Never
Nope,
good.
never good.
So sensory symptoms can range from meh to the sheets touching my leg feels like a hate crime.
Hypersensitivity to the weight of a bed sheet hallmark drama. 10 out of 10, do not recommend.
No. Can you imagine just the weight of a sheet causing you 10 out of 10?
Right,
No,
kind of
no,
like
no.
with gout, how you have to do those toe pleats.
Oh,
You might
yeah.
have the same things.
No, don't put me down for that.
Mm-hmm.
Diagnosis is based on clinical progression plus a lumbar puncture. What we look for there is for an elevated protein, a normal cell count, and that classic albuminocytology dissociation.
In other words, protein said, I'm going up, and cell said,
Not me,
though.
Electromyography, EMG, can also show slowed conduction or blocked conduction.
Treatment. Treatment is big guns. We're not going to mess around. IVIG or plasmapheresis, sometimes both.
Yeah, and because symptoms can progress fast, many patients require ICU level monitoring. Even though we said it could happen between hours to even weeks, sometimes it can progress very, very quickly.
Yep, so we need them to be in the ICU because we're watching for what, Lisa?
We're looking for that ascending paralysis.
And respiratory failure.
Yes.
Yep.
Once that diaphragm is stuck, you're screwed.
Yep. Most patients will recover after about a couple weeks of their worst symptoms, but full recovery can actually take months to years.
And about 30% have persistent deficits, which is why early recognition matters.
This is where supportive, meticulous nursing care is everything.
Airway, respiratory monitoring, pain management, because demyelination hurts like betrayal. Skin care, positioning, prevent complications.
And this is kind of the one that confuses students sometimes too, because we're always talking about movement. But the big rule here is in that acute phase of Guillain-Barré, no unnecessary movements and no passive range of motion in the acute phases. It can make the pain worse.
Yes, save that range of motion for later when the nerves aren't screaming.
So that's Guillain-Barré, ascending paralysis, immune chaos, and a recovery curve powered by myelin making a slow comeback tour.
If someone has rapidly progressing symmetric weakness, don't wait. Call Neuro, call ICU, call whoever has coffee.
This is just hard, where the disorders are confusing, but the host, unbothered, supported, ascending.
Not ascending paralysis, though. We're ascending professionalism.
Debatable. And now it's time for a unsponsored commercial.
Not sponsored, unfortunately.
Right. Today's episode of Just Hard is brought to you by absolutely no one. Not one company, not even a coupon. But if we were sponsored, it would totally be by IVIG.
IVIG, because sometimes your immune system needs to sit in the corner and think about what it's done.
Guillain-Barré syndrome is all fun and games until your macrophages start chewing up myelin like it's a stress snack.
That's where IVIG steps in, a highly purified infusion of donor antibodies that help neutralize the harmful immune attack, calm the inflammation, and remind your immune systems that peripheral nerves are, in fact, not the enemy.
IVIG works by modulating the immune system, slowing down the attack, giving myelin a fighting chance, and helping symptoms stabilize faster. Basically, it's the bouncer at the autoimmune nightclub.
Administered over 3 to 5 days, IVIG is one of the 2 first-line treatments for Guillain-Barré. Most patients tolerate it well, though some may experience headaches, flu-like symptoms, or that reassuring moment where you wonder, did that bag just cost more than my car?
Probably, but worth it.
IVIG, helping Guillain-Barré patients get back on the road to recovery, one immune calming drip at a time.
Ask your neurologist if IVIG is right for you.
And once again, this has been a completely unpaid message from
Just Hard. Well, Lisa, that was our whole neuro lineup. Tumors, MS, ALS, myasthenia gravis, and Guillain-Barré. If your brain feels full, congratulations. It's functioning better than half the disorders we just talked about.
And if it doesn't feel full, blame the neurons, blame the myelin, blame the synapses. Honestly, pick any part of the nervous system and it'll make sense.
The point is, you all made it through, you learned something, and you didn't flip over your desk. Proud of you.
Thanks for sticking with us through the nerdy stuff, the weird analogies, and the questionable humor.
We promise next episode will be equally chaotic, but educational. Mostly educational.
This is Just Hard.
And so is Neuro. And remember, if you didn't understand anything we said, just tell people it was upper motor neurons.
Works every time.
Thanks for listening.